Good evening, everyone. Welcome. My name is Sister Ann Norman. I'm a member of the Sisterhood of St. John the Divine, which has founded St. John's Rehab. And I'm also here as well on behalf of the Board of Directors of Sunnybrook. And it is my pleasure to welcome you all this evening. This is my first time in introducing a speaker series event, but I know that many of you have been here every month or watch it regularly through our webcast. Thank you so much for your support and your interest in these talks. Tonight, we will be discussing a topic that affects many individuals and families: how to support a loved one who has obsessive compulsive disorder, or OCD for short, or anxiety. OCD affects about 2.5% of the population, or about 1 in every 40 people, over the course of their lifetime. The World Health Organization has recognized OCD as the 10th most debilitating medical condition worldwide. Recent statistics from Health Canada show that millions of Canadians are affected by mood and anxiety disorders. In short, these conditions are common and affect many of us, our friends, coworkers, and our families. It can be difficult to know what to do, so this evening, we are very fortunate to be here for the perspectives and guidance from an incredible expert Sunnybrook panel. They will all be introduced to you in a few moments. To start, leading us through tonight's discussion is Dr. Peggy Richter. She is the head of the Frederick W. Thompson Anxiety Disorders Center, which is the most specialized center in OCD and related disorders. There, she also serves as director of a new residential program for severe OCD. This program is the only residential treatment program of its kind in Canada. Dr. Richter has been treating people with OCD, hoarding disorder, hair pulling, and skin picking disorders for over 20 years. She is also involved in various research projects, including a focus on understanding the genetic and biological basis of OCD and ways to improve outcomes. Please help me welcome Dr. Richter to the podium for her opening presentation and also to get all of this evening's discussions underway. Dr. Richter.
Okay, let's see. Can everybody hear me okay at the back? Good, okay. Well, it's my great pleasure to be here for another one of our speaker series on OCD and anxiety. And I want to, in particular, thank Monica Mattis with the hospital, who's here somewhere in the crowd or maybe outside stage managing everything, as she is behind the wonderful speaker series that are run here and has been an incredible source of support to us as we try and do these events at least annually. I want to thank Sister Ann so much for coming. The support of the board has been instrumental in helping us develop some of the programs we are so happy to be developing here at Sunnybrook. And I want to extend a warm welcome to all of you. I think many of you have been to one or more of our previous speaker series talks. I think we've done around 8 or 9 since opening the Thompson Center here. So I'm sure there are many in the audience. How many here have been to one of our speaker series events before? My goodness, and how many have been to some on anxiety, OCD specifically? Yeah, well, hopefully you're here, and that's a good thing. I'm hoping that that doesn't mean that we didn't teach enough, but that you liked it so much you wanted to come back for more. So it's lovely to welcome you all back again. I want to note to you that the webcast archive of this event should be posted within the next week and can be accessed through the Speaker Series homepage on the Sunnybrook website. So give it 1 to 2 weeks and it should be up there if anybody feels they've missed something and wants to be able to review it. It really is a fantastic resource. Thank you, Kevin, and our AV people for making that happen. Our talk tonight is called All in the Family, Supporting a Loved One with OCD or Anxiety. And I think it's a really interesting topic. Obviously, you're here tonight because you all agree. Because when it comes to OCD, it really is part of the family, and the same is true of all the anxiety disorders. Forgive me that my bias is a little bit more towards OCD, and I think the evening will be more biased a bit on the OCD side, because in the Thompson Center, that is our focus. But really what we're talking about in terms of the ways these illnesses can affect family members and the impact they exert and ways for coping with them as somebody who is helping provide some caregiving or support to a loved one with these problems is similar across the spectrum. So everything we do talk about tonight should be pretty broadly applicable to a host of problems. We have a great panel of speakers for you this evening, and at the end of the presentations, we'll hold a panel discussion with questions and answers. There should be cards floating around on the chairs, and I want to encourage any and all of you, if you have questions, feel free to put them on a card, and in between the various speakers, we'll be coming around to pick up those cards, and we'll try to get through as many as we can over the course of the night before we have to end. Usually we get to most of them, maybe not all. It depends on what comes our way, but we'll do our very best. So please do feel free to write your questions down and we'll get to them. I also wanted to draw your attention to Sunnybrook's weekly blog, which is called the Personal Health Navigator. Just out of curiosity, how many here have seen the blog? Any? So this is something to be aware of. It's written by former journalist Paul Taylor and published on our website, and the blog provides advice to people about the hospital and their health care and relies heavily on a lot of the wonderful healthcare experts here, including myself if I can, but really depending on all the great people at this hospital to help provide interesting pieces that go on there. You can also send your questions to askpaul@questions.ca. And again, I can repeat that later. Oh, I think it's on the website as well. And we can try and get to those after if we need to. So we can try and get back to you by email later. Okay, you'll also find evaluation cards on your chairs, and we do ask you to fill those in. Forgive me, I'm just trying to read this through tonight to make sure I don't miss anything. Please feel free to get up if you need to during the course of the evening. We won't be taking a formal break. We'll be going through till 8:30 tonight. And there are washrooms located just outside the auditorium. And as you've all probably discovered, there are lots of refreshments out there. So if anybody needs to go, feel free. Just try and keep the volume down so we don't disturb the speakers. And as a courtesy to everybody, I would ask you to please take a moment, just check your cell phones and put them on silence if you can, so that they don't interrupt us during the middle of the talks today. Okay. So what I'd like to do is to kick off the evening with just a very bit of a brief introduction about the nature of the disorders we're going to be talking about. Okay. Let's see. Yes, perfect. So I wanted to start by just briefly introducing the concept of anxiety to everybody, and I think we all know anxiety. We all experience it here. That is something I won't ask for a show of hands about, because if I did, everybody's hand would be up. And part of the reason anxiety is so ubiquitous is that it has survival value, which I think is something a lot of people forget about. It is such an uncomfortable feeling when you feel too anxious that we just think of it in negative terms. But what we forget is that we were selected through evolution to be prone to certain levels. Can we get those lights back up? Kevin, if that's, oh, there we go, thank you. Through evolution to experience anxiety because it actually enhances our survival. It turns out that when you're confronted with a life-threatening situation, being a little bit anxious helps you run a bit faster, maybe fight a little bit harder, be more vigilant, take in more that's around you, and as a result, enhance the odds that your ancestor who experienced this anxiety reproduced. And that's why these traits are so ubiquitous in us today. There's an example of a more contemporary threat, right? You don't want to be trying to cross a road like that without some anxiety to keep you on your toes. Well, actually, most of us don't want to ever be crossing a road like that. But Yonge Street or Bayview can feel a bit like that sometimes, right? So many of us, I think, feel like we're taking our lives in our hands sometimes when we're crossing streets. So the point then is that anxiety is adaptive. It helps us to plan and prepare for threats, and to a certain extent actually enhances our ability to learn and take in what's around us and perform better. The problem is only when it becomes really too severe, when it can impair our ability to function, or really chronic, ongoing. And that's when we begin to identify it as a problem. When we talk about the anxiety disorders, another relatively common feature to them is that helps us to differentiate anxiety from fear is that we're more likely to call it fear when there's a real threat present. So last week when I was walking between our program at Bellwood, or actually about 3 weeks ago, and our program at Sunnybrook, and there was a snake in the path, it was reasonable for me to experience a moment of fear, right? There was something that was potentially threatening. It really wasn't threatening. It was a really benign little snake, and he just went his way, and I went mine, and all was good. But I think the point I make is that, of course, we expect to experience it in situations like that. Most of us begin thinking of it as a problem when the threat is really very minor or not really there, but something we perceive to be there or in our mind's eye is there. And that's when we really think of it as a problem again as well, because there's nothing really there threatening us. The example I have on this little slide, I don't know if you can read out what the fish is saying there, but the fish is worrying that he can't swim, right? So that would probably be anxiety rather than fear because there really is no threat that the fish can't swim, just to bring that point home. So we think of them as disorders when the pendulum swings too far, people experience really chronic or severe levels of anxiety that is in excess of what they think is reasonable and becomes distressing. Now, there's a whole host of disorders that we think of under the title of anxiety disorders, and I want to quickly just run through them. We're not going to be getting into details about them tonight, but just to give you a clear sense. So I think most everybody actually probably is pretty familiar with the idea of generalized anxiety disorder. We sometimes call it the disorder of worry. This is like the worry that we all experience, but begins to reach a threshold at which we diagnose it when it interferes with a person's ability to function normally. They become very distressed by the anxiety, and it persists for 6 months or more. So again, I'm actually going to hold questions if I may, but if you please write it down on the card. Oh, is the light too bright for people? Sorry? Oh, the flickering. Yeah, I don't know. This has not happened before, so I will ask AV to please see whether they can turn some of them. Yeah, hopefully we'll fix that. Sorry about that. Okay. So generalized anxiety disorder then is that problem of excessive worry. I think we all know what it feels like. The problem is that it's prolonged here and in excess. Specific phobias, I think, similarly, I probably don't really need to talk about at length. I think we all have a concept of them, and most of us will have at least what we would call a sub-threshold version. So most of us have, for example, a bit of an excessive fear of spiders or mice or snakes or something, but as long as it doesn't get in our way, we don't normally diagnose it as clinicians. So we only call this a phobia when it begins to interfere with the person's ability to function. Okay, and as I've got kind of illustrated on this slide, there are a number of triggers I think that most of us are familiar with. So they can be natural things in the environment like heights or thunderstorms or water for that matter. Animals like snakes, mice, and the like. For some people, the sight of blood or knowing that they're giving blood or injections will trigger a very significant reaction. And for others, it's situations that are more part of modern life. especially like being in enclosed spaces, being in elevators, for example, being on bridges, being on planes. So we all know those kinds of triggers. It's also important to keep in mind that many of the anxiety disorders can feature what we call panic attacks, which are sudden acute episodes of intense fear or anxiety that may seem to come out of the blue and typically come with a host of physical symptoms. So people will typically say, I don't know what happened. I was feeling kind of anxious and suddenly my anxiety went through the roof. I felt like I couldn't breathe. My heart was pounding so fast. I was shaky, I was sweaty, I was worried I would faint or something bad would happen. And these can last anywhere from 5 to 60 minutes sometimes. So these are very, very uncomfortable for people. And we normally diagnose what we call a panic disorder when people have repeated episodes of these out of the blue. But the important point I want to make is that most of us will have occasionally in our life potential panic attacks. And as long as they don't trigger recurrent worry or anxiety or big changes in our behavior because we're so fearful of them, we don't consider that a big problem. It's in the range of normal. And many of these other disorders can also trigger panic attacks in people who have them. I think we often think of panic as linked to agoraphobia, and most people have an idea about what agoraphobia is. The term is often bandied around, but often a little bit misused because many people may know it comes from the Latin term or the Greek term actually, agora, for marketplace, and think of it as a fear of open spaces. But in fact, agoraphobia is really the fear of being in any place where an individual may not be able to get help readily. So that can include big open spaces, like being in a marketplace or a big shopping mall. It can also include being very alone or being in a closed small space where they might not be able to escape easily from. And so people with agoraphobia over time will describe having usually episodes of panic when they're stuck in these situations, or try to avoid them entirely unless they can go with somebody as a source of reassurance and support. Social anxiety disorder is on the spectrum with normal shyness, but again, when we diagnose something that we call social anxiety disorder, it's usually because these symptoms are clearly in excess of what most people would consider reasonable or a functional degree of shyness, to the point that their anxiety about embarrassing themselves or humiliating themselves leads to real impairment in their ability to function. So people with social anxiety disorder may avoid casual conversation, may avoid being in crowds, may avoid any kind of social functions. In worst cases, they may be unable to make eye contact and be very isolated at home. So it can be very, very disabling. Post-traumatic stress disorder is actually a somewhat different issue in that now, from a diagnostic perspective, we no longer cluster it with the anxiety disorders, but we did until recent times, and it certainly does share as a common feature high levels of anxiety. So we won't be addressing that. There are certain very important differences when it comes to PTSD, but just again to briefly remind people, because I think most of us have some idea about what PTSD is about. This describes a whole constellation of symptoms that people will experience after a very significant, typically life-threatening trauma, either where they themselves felt that their life was in danger or those around them were endangered. So we think about it, for example, as being a very significant issue in soldiers coming back from terrible scenes of warfare, in immigrants who've experienced horrific adversity, maybe before they were able to escape their home country, and certainly anybody here who has been through a very life-threatening situation. And last but not least, I want to just briefly introduce OCD, which at the Thompson Center is actually our main focus. And in OCD, we're talking about a disorder that's characterized by two main features. People with OCD will experience obsessions or intrusive and unwanted thoughts that they can't seem to push away. So sometimes we use a shorthand term of sticky thoughts to get at this idea that we all will have unpleasant thoughts. That's a normal part of the human condition. But imagine if the odd, weird, unpleasant thoughts that cross your mind occasionally persist, for those of us who don't have OCD, persisted for hours on end, to the point that you couldn't think about anything else. How distressing would that be? and that's an ordinary feature for people living with OCD. And in response, people with OCD typically engage in what we often call rituals or compulsions, which are repetitive behaviors somehow in their mind intended to prevent the bad things they worry about happening. So I think the most common examples are people worrying too much about germs, dirt, contamination, who engage in a lot of hand-washing compulsions or rituals, right? If I'm worried that my hands are filthy because I touch doorknobs and I'm really worried about communicating them to my mother, I'm going to wash my hands really carefully, and that makes sense on the face of it. But when it begins to take over your life is when we start talking about OCD. In the similar way, people may worry excessively about making mistakes, not having done things correctly, and that may lead to a lot of checking of the front door, of the stove, of the taps, and the like. But the important and interesting thing, I think, about OCD is that really it can be about anything and everything. So I've given you a few of the most common kinds of presentations, but obsessions can be about everything from the ordinary to the most extremely unusual kinds of thoughts. And the compulsions can range tremendously, including behaviors like repeating actions and counting and needing things symmetrical or just so, having to think certain thoughts to cancel out bad thoughts, or repeating phrases over and over again. And so I think that adds sometimes to people's confusion with OCD as a diagnosis. Last, I just want to mention that although tonight is not so much focused on treatment so much as it's focused on how to talk about it in the family, how to help deal with it better, and how to manage your own well-being as somebody supporting someone with anxiety or OCD, I want to just mention that for the individual with OCD, where things should always start is with a good assessment by a healthcare professional to clarify the diagnosis and make sure, in fact, that we understand the nature of the problem. And based on that, we usually will direct people to treatment. And keep in mind that there are two types of treatment for which there's really strong evidence and really very good effect. And those are a form of psychotherapy called cognitive behavioral therapy specifically. And that's an important thing to keep in mind because not all therapy is equal when it comes to OCD and anxiety. Now, there are other therapies that are increasingly being seen, though, as very, very helpful to OCD, and I think Dr. Selchen may touch on some of those a little bit along the way with his talk. But I wanted to make that statement. The other kind of treatment, of course, is medications, which also can play a very major role for many people. Okay. So last but not least, we do our best to be available at the Thompson Center. We certainly will try our best to respond to anything quickly that comes our way, and we certainly are open for referrals from our local community and for people with severe and debilitating illness from across the country, in fact. If you have any questions, or actually if you also want to be on our email list to know about future events, there is in fact an email address here that you can send emails to. And if you let us know, we can add you to our list so you'll automatically be emailed about future educational events. We also have an area on the Sunnybrook website which has lots of further information for you. So with that, I'm going to move on to our next speaker.
Here we go.
And a reminder, if there are questions, please use the cards. And it gives me great pleasure to introduce one of our mental health clinicians, Ketrina Dilo. Ketrina has a master's in social work degree and is a registered social worker, as well as a registered psychotherapist. She began her social work career in the areas of domestic violence, abuse, PTSD, and war trauma. And before joining us in the intensive treatment program for OCD at the Thompson Center here at Sunnybrook, she worked as a psychotherapist in a community health center setting, focusing on issues such as depression and anxiety. And we're delighted to have her with us, and we're delighted to introduce her to all of you this evening. Please welcome Ketrina to talk about understanding OCD.
Thank you. This one? Okay. Thank you. So hello everyone, and thank you for having me. often people wonder, what is it like to be stuck in an OCD loop? I guess this slide is quite self-explanatory, but often people describe living with OCD. I think, okay, it's a bit loud. Okay, often people describe living with OCD as like having a bully that torments you anywhere from few hours a day to every waking moments. Often people with OCD suffer in silence, and they feel ashamed or afraid to talk about their symptoms. So knowing more about OCD and how to help a person who is struggling with OCD, I think it's important in order to lead to better understanding and compassion for the loved one who is struggling with OCD. So what is OCD? OCD, from a more clinical perspective, OCD is described as this a condition of internal discomfort. It's characterized by the presence of compulsions and also obsessions. For a person to be diagnosed with OCD, often the symptoms they have to be debilitating, they have to be time-consuming, and has a huge impact has a significant impact into their daily functioning. Some other facts about OCD is that it's the fourth most common psychiatric disorder, the 10th leading cause of disability, and is found in approximately 2% of the population. So when we think about, when we talk about obsessions, we can think of them as these repetitive, unwanted thoughts, images, or impulses that are quite intrusive and uncontrollable. Often they are quite distressing for the person with OCD because these unwanted thoughts go against their core values, their morals, their personality. And often the person with OCD tries very hard to resist these unwanted thoughts, and also, but they have difficulties getting rid of them. So in OCD, there is a wide range of different obsessions. Some of them might include like thoughts and fears of contaminations, or harming someone, or having a disease, or maybe religious preoccupations. Some examples of obsessions can be like thoughts such as I touch garbage and my hands are contaminated, or what if I left the stove on? Or sometimes people might have thoughts of maybe which are more related to religious obsessions, such as maybe selling someone's souls to the devil, etc. Compulsions, on the other hand, is this repetitive action that the person feels compelled to perform in order to get some sense of relief from the distress associated with all of obsessions. And often they feel driven to engage in this compulsion in order to reduce their anxiety and to prevent something bad from happening. So let's take an example of somebody with harm compulsion. Let's say that the person is being tormented by the thought of or image of stabbing their wife, and they feel terrified by this thought. They feel ashamed. They have a great sense of guilt, and they are very motivated to try anything in their power to really stop these thoughts from happening. So this person will engage in praying rituals in order to cancel this bad thought. Or if we take another example of someone with a contamination obsession, let's say that they have the thought or fear that their hands are contaminated, they're going to maybe cause their children to be sick after touching garbage or some sticky residue. So they feel this urge or to really engage in hand washing in order to relieve this distress associated with these thoughts. So the same thing as obsessions, there is also a category of, okay. Sorry, I'm just going to move through this because I know we only have 15 minutes. So these are some common obsessions, contamination, aggressive harm obsessions, or sexual obsession, religious or somatic obsessions. And also Can
you slow down a bit?
Okay, sure, sorry. And also, we have a different types of compulsion as well, such as washing, cleaning, ordering, counting, and repeating as well. Engaging in compulsion often can be very distressing for someone with OCD. However, they feel like they have to engage in them in order to get some sense of relief from that pain that they feel in the moment. Even though the pain might be triggered by a false alarm, still for them it's a pain. Compulsions, what we know about compulsion is that they make the OCD cycle worse, they intensify that. Even though the purpose of the compulsion is to really reduce anxiety or to give the person some sense of relief, often this relief is quite temporary, it doesn't last, and with time, sometimes the person doesn't feel any relief at all. And therefore, these rituals become more time-consuming, more tiring, and also they become bothersome, not only for the person with OCD, but also for the family members who might be affected by it. So now I want to walk you through a typical OCD cycle in order to illustrate more how powerful OCD is, and also to have a better understanding sometimes what starts this cycle and what keeps maintaining it. So this is an example of contamination obsessions. So basically anything can trigger an unwanted thought, or anything can trigger the cycle of OCD. So can be a thought or can be a situation that can trigger it. So in this case, the trigger for this person, let's say they wake up in the morning, they're taking their garbage out, and that situation can trigger the intrusive thoughts like, oh, there are contaminants in the garbage and they are dangerous. So one thing important that I want to point out here is not so much about having these unwanted thoughts, because I believe that most people have unwanted thoughts. Actually, I think sometimes when I take garbage out, I have this thought, the thought of maybe garbage being contaminated or there are contaminant in the garbage might cross my mind. But I would kind of treat it as, oh, that's just a weird thought, and move on to something else. So, but for a person with OCD, it's different. And what differentiates them from a person with not OCD is the way how they interpret their intrusive thoughts, or the way how they evaluate them. So often they evaluate them in a negative way. So maybe having this thought means that there is something important, or I need to pay attention to it. Or in this case, what's the worst that can happen? So this person who has afraid of contaminants in the garbage, he might think that I'm going to spread the contamination and I'm going to make my children sick. And everyone is going to think that I'm irresponsible and a bad mother. So once a person thinks all this, then their anxiety increases, and they start engaging in excessive cleaning or rituals in order to reduce that anxiety, and keep thinking that I must do everything I can to not be responsible for spreading germs, and then anxiety reduces. Unfortunately, the reduction of anxiety or the relief is temporary, because the unwanted thought maybe come back, they get triggered again, the appraisal of obsession comes back, and the person feels even more compelled to engage in these rituals in order to relieve that anxiety or discomfort feeling. And this is how this cycle starts, and this is how it keeps it's being maintained. So this is another example of another OCD cycle, but mostly that targets the harm obsession. So it starts with a trigger. In this case, this person is standing in the kitchen, cutting the cake. The moment that make contact with a knife, it triggers intrusive thoughts of like stabbing his wife. And the moment that he becomes aware of these unwanted thoughts, then he proceeds to evaluate or interpret this as meaning that if I keep having these thoughts, I'm going to lose control, and maybe one day I'm going to act out on them. Or maybe I'm such a bad person for having these awful thoughts. So his anxiety goes up, and then he starts engaging in rituals in order to feel that sense of relief. For example, praying repeatedly, or suppressing the thought, or avoiding using knives altogether. And it keeps, being stuck on the thoughts of I'll control outcomes by controlling my thoughts, or if I pray hard, I will be able to cancel the badness of my thoughts. And anxiety reduces, but this is temporary, and the cycle starts again. Now, often people wonder or ask if there is a cure for OCD. So what we know about OCD is that it's a chronic condition that waxes and wanes through life, but we know that with the right treatment, the person can gain some control over the symptoms of OCD. Talking about the right treatment for OCD, cognitive behavior therapy is shown to be the gold standard treatment, which targets the appraisals, the thought that we talked about, and also the rituals. So basically, just to summarize it quickly, what we do in the CBT is that we bring those people's fears up, make them very close, so we trigger those fears, and then we have them respond to those fears without engaging in compulsions. For example, the person who was taking garbage out, one way of doing this exposure therapy with them is that having them take the garbage out without wearing gloves, or refraining from washing hands after, or maybe contaminating other areas in the house. So in this way, it will allow them to respond to their fears differently. So new learning can take place. So now, how to talk about OCD within the family? I know most of you who are here and have a family member who is struggling with OCD. You are probably deeply involved in trying to help them to cope with OCD. And maybe some of the things that you are using, you find them quite helpful, and some of them not so helpful. Today I'm going to talk about a few ways of strategies of how to help someone with OCD that you might find useful. So when a family member has OCD, it's a very good book from John Hirschfield, and it talks about 4 I's of helping a family member with OCD. So what are these 4 I's? So the first is identifying the compulsion, not the person as the problem, inviting collaborations, interrupt the obsessive compulsive cycle with permission, and integrate a model healthy behaviors. So I'm going to talk about the first 2 in my presentation, and then Sandra with Carrie, the rest. So identifying the compulsion, not the problem, not the person as the problem. So often a family member with OCD, a family member of a person with OCD might feel quite frustrated if they witness their loved one, their daughter, their son, or their partner getting stuck in rituals for hours, having difficulties leaving the house, and sometimes they might deal with this frustration by criticizing them. But what we know about criticism is that it doesn't really work. If anything, it reduces the anxiety and also might trigger for the person with OCD to become more critical towards themselves as well. It's important here to keep in mind that the struggle is that the person with OCD is they are feeling compelled to really engage in these urges and rituals. And if they are engaging these urges in these rituals, it is not because they feel like, but because they truly feel like it's important to do this. Because again, they feel it's important in order to deal with the pain that they are feeling in the moment. So I just want to illustrate a little bit more in depth about why often the person or family member with OCD feels compelled to engage in rituals. Often their experience of someone with OCD can be totally different from someone without OCD. And often the OCD can distort their reality. For example, if someone without OCD, when they look at the bread knife, they see a bread knife. But for somebody with OCD, looking at the bread knife also reminds them of that she possesses a harm to the family or a friend, or if they see a scarf on the wall, to them is a potentially disease-spreading contaminant, or it might trigger that not just right feeling and the urge to perfect things. Or if sister shares that she has upset stomach, the sibling with OCD is consumed with the fear that sister has cancer. So often the reality of a person with OCD or a person without the OCD is completely different. You see what things are, and your family member with OCD see what things could be. So this is an example of how to importance or identifying the compulsion of the problem and another person as a problem. Let's say for example, you are about to go and attend a family dinner, but your son or your daughter are getting stuck checking the front door. They have hard time letting go, and you might feeling frustrated because it's making both of you late for attending the family dinner, and you might try to allow them extra time to probably complete their checking rituals, or you might try to check on their behalf in order to save both of you time, which sometimes might cause some frustration as well, because now you're being late for the family dinner, and also might create some tension between you and the person with OCD. So something important to keep in mind here is that naming that the problem here is the checking the ritual, not the problem, not your son or your daughter are getting stuck with that. And also is the checking ritual that maybe is getting in between you and your loved one, is creating this tension. Or maybe it's the checking rituals that getting between you and you wanting to be on time for the family dinner. Also, it's important to have in mind that these rituals, they not only affect the family, but also they affect the person with OCD. In this case, the checking ritual might be getting in the way of them missing school or social engagement or disrupting their vacations. So again, it's important to identify the behavior as a problem, not the person. This is an interesting example of how to look at checking rituals from a non-OCD perspective and OCD perspective. So from an OCD, also sometimes rituals can be part of the normal human experience. So from a non-OCD perspective is that we all check sometimes, but often you will check once or twice, and then once the task is accomplished, then you move on to something different. You get the message from the brain is got it done and on to the next thing. But somebody with OCD, they don't get the same message. They are waiting and scanning the mind for it, and they find nothing. Their mind the task might not be completed and go back and forth and check. It does it over and over until the brain forces a sense of completion, long enough to get them out of the house or far enough away to not turn back. How am I doing with time? We're done?
Almost finished.
Okay. So last thing, actually, we're done with time. So the second step is really inviting collaboration. So it's working along with your loved one in order to collaborate together or dealing with OCD and coping with it. So to conclude, I think OCD in itself can have a devastating impact, not only a person with OCD, but also family members. And I think when family member and the person with OCD work together in collaboration, I think they can stand, they better can stand against OCD. Okay, thank you.
Thank you.
I'd like to thank Ketrina and now introduce our next speaker, and that is Sandra Cushing. Sandra is a social worker with our Thompson Center and working in our intensive residential treatment program. And she has extensive training, including a master's and bachelor's of social work, and began her career actually in the areas of child welfare, first-stage trauma, and co-occurring mental health and addictions, and worked for 14 years at CAMH, where she was a lead in the area, working with clients, families, and team members in the early psychosis program. And we've been delighted to have Sandra with us in our intensive OCD treatment program since our opening last summer, and very fortunate to have her with us here tonight. And Sandra's going to continue this discussion that Ketrina so beautifully began around illustrating how to talk with family members. Thank you.
Okay, thanks. Okay. Good evening. Welcome, everyone. Nice to see such a great turnout. This topic is near and dear to my heart. Most of my work at the Thompson Center is with family members. So I'm going to continue on following with the 4 I's of helping for family members how to help someone with OCD. But I just want to talk for a few minutes about the impacts of OCD, which we know are tremendous and very varied and quite different and unique for each family. But many will say that having OCD in their family is like having an intruder sort of come in and take up residence in their home and call all the shots. And that could be because maybe family members are having to live by certain rules that the OCD really wants. Maybe the person has contamination OCD and they want people coming into the home to always change out of their street clothes into clothes that are safe or clean to wear in the house. There are many, many impacts. Just move ahead. Oh, sorry. There. And the other piece is that families are like mobile. So when OCD is impacting the family, we know that pretty much everybody in the family is affected. And this is true for many, whether it's mental health or different types of physical health illnesses. What we do know, though, that with OCD, because it usually involves, or other people get involved because they're trying to help alleviate the distress of the person with OCD, more so than a lot of physical and other mental health diagnoses, it really involves the family. Or even if the person isn't living with their family, often friends or people close to that individual or their family members, if they're living somewhere else, are doing things like providing reassurance or accommodation to try to help that person reduce their distress. These are just some of the emotional impacts that I hear from family members, and again, it can be quite varied, but often in the beginning, there's especially the sense of helplessness, of being really uncertain about what to do, how to help, what is this sort of monster that some people describe or have trouble understanding. Family members may also experience a lot of frustration and anger. In their mind, they might be thinking, just stop checking or stop washing, you're making me late for work. But as Ketrina was saying, we really want to shift that anger toward the OCD and away from the person, toward the ritual or toward the obsessive thought, because it's so compelling and difficult for the person. They don't want to be checking or washing or making everyone late either. Often family members will feel a sense of guilt if someone has like a harm OCD thought or an obsession about preventing everyone from getting sick. So maybe they're worried if, say, their sibling has a cold, and then they're worried that that person could die, or they'll bring the sickness into the house, and then someone else might die. So sometimes family members will start to feel guilt, like, did I instill that type of belief in the person? We see a lot of withdrawal for a person with OCD, a lot of isolation. They might start pulling away in their own lives from friends or family as well. And so sometimes family starts doing that too, because maybe they're trying to either stay behind and support the person, or maybe the person with OCD, their OCD might make it difficult to go out and socialize in events that they normally did together as a family. Stigma is a big common sort of emotion that both the person with OCD and often family members experience. There could be a lot of fear about how will people react. What if they don't understand OCD? There's a lot of sort of, I think, like minimalizing of OCD in the media and not really fully understanding. So I think even family members are reluctant to sometimes share to a friend like that my son or daughter or partner has OCD, just because they fear that they may not understand it. There's a lot of pressure having to abide by OCD rules. I'll talk about more of those in a moment. And less time for other family members. And I just wanted to highlight that a bit because sometimes I think that gets overlooked. We're often spending so much time trying to help the person with OCD and their family, but the impacts for siblings are tremendous, or just other people in the home. If a spouse has OCD, then maybe the parent, or sorry, the partner may also be spending so much time helping their spouse that the siblings or their children don't get as much focus. And same with siblings. We hear a lot about the focus is always on the person with OCD. So the impacts can be quite tremendous. Just again, having to follow these rules that OCD is imparting on the family. So siblings also having to sometimes follow those same rules. Again, everyone needing to change into inside clothing or wash their hands, or if they're getting something out of the fridge, they have to wash their hands before doing that. Or if someone has harm OCD, they might be triggered by the news or movies where individuals are being hurt or something sort of difficult is happening. So they might have sort of this rule that we're not going to watch news or movies that could be triggering, but that might not be fair for other people in the house that want to watch those things. But then siblings or other family members can get upset if they have to follow by these rules. Some common reactions of family members, sometimes there can be denial, especially in the beginning about what's actually happening. So this was a comment, why do you make such a fuss? Just let the person with OCD continue to count and recount their emails and texts. It could be worse, she could be on drugs. So not maybe fully understanding it. Maybe that checking is taking hours of their time or is really impactful. Another response is rejection. So just like getting really annoyed and angry at the person and not recognizing, like maybe not knowing a lot about OCD or how difficult those obsessive and intrusive thoughts are to manage. So there might be reactions like just cut out the hand washing, look at your hands, they're red and chapped. This isn't normal, and if you wanted, you could just stop it. You won't allow anyone to visit because of your germ fear. I'm not going to keep living like this or put up with living like this. So this can happen sometimes. What we see the most often happen is accommodation, and this is where when family members are participating in the person's rituals, even though they don't really want to, they're just trying to help move things along or keep the peace. So an example of an individual whose wife wants them to change when they come home from work because they're concerned about again, contamination, then maybe they're feeling if I go against if I go against my wife's rules and go and sit down and watch the soccer game or something as soon as I come home from work, the last time I did that, she landed up in hospital because it was so distressing. Or another person might be getting up early to order their daughter's briefcase or school bag before they leave the house, and that might be taking up a lot of time, but they're trying to do that to save everyone time and get out the door. So one thing we know when we're working with families is trying to get an understanding of each family member's reactions, and trying to get a more consistent approach. As we start to work on accommodation, we try to get accommodation happening, but also, or reducing the accommodation, but also validation happening for how difficult it is and having a more of a consistent approach by everyone in the family. So again, just a definition. Family accommodation refers to the ways that the family members or friends, it could be friends or colleagues or people close to that person, that they're taking part in either performing the rituals along with the person or helping them to support avoiding anxiety-provoking situations or triggers, or they might be changing up their routines, not going to things, arriving late to try to support the person with OCD. And again, the accommodation is quite high. Upwards of 88 to 90% of individuals are accommodating the OCD. And this is not meant to criticize family. It comes from a place of caring and wanting to help that person with OCD. And that's something we really emphasize with families, is not to be critical if you are accommodating the OCD. Ketrina talked about a few of these. I'll just highlight a couple more, and all of the slides will be available on the website for you too. But if someone with harm OCD, maybe you're driving to work together, and maybe you're the driver and the person with OCD is a passenger, you go over a speed bump, and so right away that might trigger for the OCD, that the person with OCD, that they've hit something or hurt an animal or run over a person, and they insist that you go back and retrace the driving route. And so doing that would be accommodating the OCD, but in the moment you're trying to just get to work and reduce that person's distress. buying large amounts of laundry soap, paper towels. That can be something we see for contamination OCD. For people who do a lot of checking of paying bills, sometimes family or friends will swoop in and just sort of pay the bills for them. So that would be accommodating the OCD, or just doing cooking, cleaning. Sometimes OCD takes up so much time that people just can't get to regular household responsibilities. So family members might step in and do those things on their behalf. We've talked about participating in rituals. I know of one individual where the family was having to wash the groceries before putting the groceries in the fridge, because that's what the OCD wanted. The person with OCD wanted that. Or just providing lots of reassurance can be another one. The next couple of slides, I'm just going to talk very briefly about how we try to sort of pull back on the family accommodation, and just acknowledging Barbara Van Nopen, who created these slides with the University of Southern California. So just in a scenario, if the individual has contamination OCD, and maybe everybody's in the kitchen and that person touches the countertop, and the obsessive thought gets triggered that there might be germs on the countertop, they're going to get themselves sick and maybe people in their family sick, having a lot of anxiety or disgust or distress. And so the compulsion is they want to seek reassurance, maybe from their mom or dad, that there's no danger. And so the parent provides that reassurance, and the anxiety reduces, but unfortunately the person will keep wanting that, and sometimes upwards of, in the course of 15 minutes, the family member is having to provide that reassurance over and over again.
What does that say, please?
Oh, sorry, family accommodation. So in contrast, when we're trying to interrupt that cycle, the same scenario, but this time the parent doesn't provide the reassurance. And like Ketrina was saying, the one thing we want to do, we want to not just stop doing it cold turkey, but with collaboration. And so if we've sort of pre-agreed that we're not going to provide reassurance anymore, or we're going to reduce the number of times we provide reassurance around contamination OCD in this example, then it will be difficult. The person will still have anxiety and incredibly difficult, like disgust or fear, but they'll learn that they can actually manage it, and they don't have to have that parent constantly providing that reassurance in order to get the anxiety to reduce. Or sometimes it doesn't reduce, and they learn that they can still go about their day, even with a degree of anxiety and fear present. So when we're trying to sort of work with that cycle, it does involve interrupting the OCD cycle, but we really want to do it collaboratively, with permission, talking about it. If the individual with OCD is working with a therapist, maybe you can work together with that therapist on reducing the accommodation. When everybody's on board, then you're going to figure out how can we get in the way of breaking down the OCD cycle. But again, it really should be done with permission and gradually. Just another example, maybe the person with the harm OCD, where I mentioned that people in the family haven't been allowed to watch news or movies, and maybe they're going to start being able to do that. And so maybe mom or dad is sitting down to watch the news for the first time in a while, and they might say to the person with OCD, I know it's really hard for you to watch the news with me because I know you might be triggered. But I know you can handle it, or I may not know exactly how you handle it, but I'm here for you. And I'm here if you're ready to try to sit with me. But either way, they're still going to watch the news if that's what they're wanting to do. Okay, and then the other thing is, as the OCD starts to reduce, or even if it's not, the one thing I hear from families a lot is that all we ever talk about is OCD. And so trying to ensure that there's still time to talk about, other meaningful conversation or other things of interest. So still trying to build in ways to keep those other aspects of life going and not let every conversation be about OCD. And Dr. Selchen is going to talk a little bit more about this, so I won't talk about this too much. But I think for family members and the individual with OCD, the one part of recovery is also trying to get back to doing things that maybe the OCD's gotten in the way from, and also family members often stop doing these things too. So finding ways to support that person in doing meaningful activity. Maybe it's just having a cup of tea together, going for a walk, doing a yoga class. Yes, yeah, turn off the cell phones, actually be together and be present with one another. Yeah, so just some examples of how to do that. And we'll hear a lot more, I think, about that in a few moments from Dr. Selchen. So there is a lot of help out there for family members. There's a lot on our website and some resources at the table. We're lucky in Toronto, we have some self-help groups, so those information about those are in the slides too. The one thing I encourage family members is to read as much as you can about OCD, to learn about your loved one's particular type of OCD. These are the self-help groups that are available in Toronto. The Toronto West Self-Help Group, I think we have Christina's here tonight, representing the Toronto West group. We have the Mood Disorders Association. They run a group for individuals with OCD and a separate group for individuals with both, or for family members and individuals with OCD. In the Toronto West group, both family and the person with OCD can attend. And then OCD Canada runs a group downtown as well. It's, I think tomorrow evening actually is their next session. So information is there for you about those groups. And then again, the International OCD Foundation is an amazing website. You can find any type of OCD featured there. So next I wanted to bring up Mary Lynn to share her story and her perspective of OCD. And again, there's more information on resources there for you too. Okay.
Thank you so much, Sandra. Just before we move on to our next speaker, just a reminder, if anybody does have any devices that might be beeping, or you're still getting texts, for example, on your cell phones, if people could silence them, because I think it can be distracting to people in the audience. And a reminder, we're happy to take questions, so if you have questions, remember, write them on a card, put up your hand, and there's a number of volunteers who are going around to pick up the cards, and we'll keep them after from you. And now it gives me great pleasure to actually introduce a guest who's not on our schedule that went out earlier. Mary Lynn Kiefer is a member of the community who has very, very graciously agreed to talk a little bit about her experience living with OCD. And we thought that would be really an invaluable way to give you that human side of the story tonight. Mary Lynn's mental health journey began after she had her first panic attack in 2009. And although it was manageable at the time, it gradually worsened, particularly in 2017, when at that time she turned to one of her sisters and subsequently was diagnosed with OCD. As Mary Lynn started her recovery journey, she was shocked to learn of the rather limited resources that are out there to support people with OCD. Because of this, she turns her energy and her efforts now towards working towards developing a charity to raise funds and awareness for OCD, and also actively working with the Thompson Centre now, where she has gone through training for peer support through the Mood Disorders Association of Ontario, and is hoping to work with us now, providing support to people who come through. Mary Lynn also has her own professional background that is separate from her OCD. So she has a master's in international economics and finance, worked in investment as an investment advisor, and is currently employed by a large law firm where she's their national business development manager. And on the side, she enjoys hunting for vintage designer furniture and fixing it up, something I think we all love to see about. So it gives me great pleasure to be able to welcome Mary Lynn tonight to tell us a little bit about her journey.
No, I don't have any slides. Okay. Good evening, everyone. I am honored to be here today to share my experience with OCD and the family support I received along the way. I was diagnosed with OCD when I was 34 years old, so approximately a year ago. My OCD manifests itself by way of intrusive thoughts with mental compulsions, mainly in the form of ruminating, and a lot of online research. Although my intrusive thoughts change, the one that took hold of me for a long time, sorry, just need a minute. Okay, no, she's going to come. Sorry, it's obviously an emotional thing to tell the story, but I think it's important. So my intrusive thought that kept coming back was, what if I become so depressed that I commit suicide? This is an example of the thought, but it would surface in many different ways. The theme was always the same. I would spend the majority of my day, for about a year, replaying this thought in my mind, and I would try to come up with absolute certainty that this wasn't something I wanted to do. If I thought it, then it must mean something, right? The mental compulsions took shape by thinking such things as, what does this thought mean? How can I think this way? Does this mean I want to harm myself? What if it actually happens? Am I depressed? Why else would I have this thought? I would spend all day, every day, going over scenarios, reassuring myself, checking in with myself, how am I feeling, doing online research, looking up symptoms of people that commit suicide. I would do anything I could think of that would help me rule out any possibility that this thought had any validity to me. Needless to say, and as you can tell, I'm quite emotional talking about it, it was a very scary time and a miserable one. A year ago, I left my job, I moved back in with my parents for 4 months, and was inevitably diagnosed with OCD and was at rock bottom. At the age of 34, being independent, working downtown, living on my own, it wasn't easy for me to move back home or to walk away from my workplace for that matter, but I didn't have a choice. I needed help and I couldn't do it on my own. I wanted to share some specific experiences of how my family was there to support me along the way, and wanted to pull on the 4 examples that Sandra and Ketrina just mentioned, the 4 I's. So the first one being identify the compulsion, not the person as the problem. What helped on my journey was educating myself and my parents educating themselves on what OCD actually is. This was a huge starting point for us. It is so hard to understand why someone would spend hours checking something over and over again, or wash their hands excessively, or research online for an answer that they will never find. I know at first my parents had a hard time understanding, and even for me who was living it, I didn't understand it myself. When we all learned more about OCD, we began to understand the strength and the power of OCD and the desperate need to carry out the compulsions. Having that awareness that compulsions are a force significantly greater than any logic I had was the first step to understanding this complex disorder. It created some separation between the disorder and myself. The second I, invite collaboration. My parents made it very clear to me from the beginning that they were there to listen, to support, and to help me in any way that they could. They never gave me the feeling that I was a burden or that they didn't have time to deal with my OCD. Although despite this, I still worried that my experience was taking a toll on them. I always made sure I expressed how I felt rather than let that feeling eat away at me. They would reassure me and remind me that they were there for me and they wouldn't have it any other way. One thing I noticed was they didn't actively try to fix me. They knew this was a journey and that we were moving in the right direction. But they did provide me with a lot of love and support. And most importantly, they gave me the space to approach them when I was ready to. This open dialogue inevitably strengthened our relationship. It also helped when family members were open about their struggles. I was being so vulnerable and sharing my internal reality, and it felt good when I got that reciprocated. It didn't matter if it was about OCD, it was just anything that they opened up about. This, of course, further established trust and strengthened our relationship. I watched a TED Talk earlier this week by Tim Ferriss. I'm not sure exactly what he does. I think he's a motivational speaker, but he also speaks a lot about Stoicism. And he said the biggest challenges and problems we face will never be solved with comfortable conversations, whether it's in your own head or with other people. I don't recommend doing it in your own head because it could turn into a compulsion. Number 3, interrupt the obsessive compulsive behavior with permission. When I was able to start identifying what my compulsions were, I was able to get my parents involved in working with me to try to eliminate some of them. For example, I would say, if you see me on my computer, I give you permission to ask me what I am doing. If I am doing compulsive research, I give you permission to take my computer away. At times, I would ask them to hide my computer and phone when I knew I was really bad that day. Although this was hard because I couldn't do my compulsive researching, it was also incredibly helpful. At this point, I felt like I had to do it for myself, but also I felt accountable to my parents, and I didn't want to let them down. Another thing that worked for me was announcing to a loved one when I had an intrusive thought. It would go something like this. I just had an intrusive thought, and I really want to go into the mental ruminating right now and problem solve why I thought that, or try and reverse the thought. They would then acknowledge that I had the thought and try to divert my attention to something more meaningful. My dad seems to do this a lot, and he manages to do it each time, but it does take quite a lot of skill to get your attention from going into your compulsion to talking about the Me Too movement or something else that's going on in the world that can be stimulating conversation. I involved them whenever and wherever I could so that I wasn't fighting this battle all on my own, which, as you can see, my mom is here with me. The 4th one, integrate and model healthy behavior. The best thing my parents did for me was to give support and love, but also they created a normal, healthy environment. They went on with their life. Things couldn't stop just because I had been diagnosed with OCD. I know when we see family members in distress, we immediately want to fix the problem. Questions pop up like, what if this takes years for them to recover from? What if she won't be able to work? What if she can't complete school? You are faced with all of this uncertainty. My parents had this faith that I would be okay.
Please, we have a code O.
And that I would come out of this stronger. I saw that, and then I started to believe it for myself. They knew they couldn't fix it for me, but they knew I would get through it. Their faith helped me have faith. I wanted to end on this note. I expressed to a friend of mine who's in the audience, Nina, that I was very nervous to do this presentation tonight. And she said to me, have trust in yourself. I think this goes for everyone here that is affected by OCD. We have to have trust in ourselves and faith that despite the unknown and all of the uncertainty, we can and we will handle it. Thank you.
Thank you, Mary Lynn, and Mrs. Kiefer as well. I think Mary Lynn showed great courage in sharing that story, and I hope that it helped bring home the horribly distressing reality of living with OCD to many in the audience, too. And I think that's a great service. One of many she's going to be trying to do in the years to come, because Marilyn really wants to do more to help OCD. And so it just reminded me, before I forget, that people should be aware that there are, in fact, burgeoning community supports out there. I know Sandra had a slide up, which will be on the website, that mentioned, for example, Toronto West OCD. There's also the Mood Disorders Association of Ontario, which runs groups for both individuals and their families. And there's Obsessive Compulsive Anonymous, and I know that Joe is here in the audience. Joe, why don't you just wave your hand. And Ketrina from Toronto West OCD here tonight. So we've been very lucky to have some of these community groups represented tonight, and they'll be out there for a little bit after if there are questions. I believe Toronto West actually has an upcoming presentation on October 18th by one of our own, Dr. Lance Hawley, speaking on mindfulness and meditation and CBT for OCD. So there is more going on than people may realize in the community. Now, last but not least, I'd like to introduce my wonderful colleague, Stephen Selchen. It gives me great pleasure to introduce Steve. He's been here on this journey with us with the Thompson Centre for almost the entirety of our time that we've been here now. Dr. Selchen is the Director of Education for the Thompson Centre, and he is an Oxford-educated and award-winning expert in adaptation and integration of mindfulness-based treatments and approaches with other psychological treatments towards recovery. As an educator, he does a great deal of speaking locally, nationally, and internationally, and particularly focusing on mindfulness-based intervention, the promotion of well-being, and innovative treatments of depression and anxiety. As if that weren't enough, he's also now the psychiatrist-in-chief at Joseph Brant Hospital, which has been great because it allows us to kind of extend our reach a little, and it just gives him even more scope for his wonderful skills. So it gives me great pleasure to introduce Steve.
Thank you. Thank you. Folks, before I get to the microphone, I'm going to test this thing. It sounds to me like you can hear me, but you tell me. You can hear me okay? All right. I'm going to come over here because we are filming, but I'm also going to disappear from this space from time to time. When I was a teenager, I was told that I had a great voice for radio, which I took as a sort of a backhanded compliment that I had no business being on television. So I don't think the camera will miss me if I step off from time to time. How moving that was, Marilyn. Thank you so much. And yeah. And to hear my colleagues speak as well. And so I'm standing before you with a couple of strikes against me already. One is those were some tough acts to follow. And number two is Peggy's introduction was too generous. So once you say like I'm an award-winning speaker, what could I possibly say in front of this audience in order to live up to that? Peggy, when would you like me to stop talking? I mean, not like right now, but like at... Okay. So folks, I think, so I don't have slides with me. Somebody put this one together. Thank you for doing that. How to take care of yourself as a caregiver. That's what we wanted to focus this last 15 minutes on together. And I think it speaks to this challenge that many of us have in terms of both caring for ourselves, but also how to care for yourself with the added challenge of when somebody that you love is struggling in this way. I like to speak last sometimes so that I can listen to other people and then try not to focus on the things that they focused on. So it's one of the reasons why I don't come with slides. But I also want to engage you, and I want to hear directly from you, and partly that's why I wanted this thing on, so I can step off the stage and talk a bit from you. Let me ask you a question. How many people in the room think that it is important for us to take care of ourselves? Okay, look around, almost everybody. Okay. How many people in the room feel like they take care of themselves as well as they should? Okay. All right. And that is the discrepancy and the challenge, right? And You know, what I'm not going to do is sort of stand here and list, you know, here are the 5 things that you should be doing to take care of yourself that you don't already know. But I do want us to talk about that. I want you to actually take a moment for yourselves. So just with yourself for a moment. You can close your eyes if you like, you don't have to. But just to check in with yourself and ask yourself a curious question. So it's not an interrogation, it's just a curious question. What gets in the way of me taking care of myself the way that I think I ought to? Just see what comes up for you. Maybe something came up, maybe it didn't. I'm now going to invite you for just a couple of minutes to turn to somebody near you, maybe the person that you came with. It may be a total stranger. It may be more fun to talk to us. Well, that's... It may be fun to talk to someone you love. It may be fun to talk to a stranger. We don't have to decide which is more fun. But turn to somebody near you, and whatever you're comfortable sharing, just for a minute or two, just check in with somebody about what are some of the things that get in the way of taking care of yourself in the ways that you wish you could. Okay. I'm gonna cut you off. People are in the middle of a vigorous conversation, but I am mindful of our time. Anyone willing to, so not what somebody else just told you, that's their business, but anybody willing to succinctly, or a couple of words, share something that gets in the way of you taking care of yourself the way you'd like to? I see a hand at the back there. Sure. Thank you for sharing that. For those of you that couldn't hear, I'm not going to do quite justice to what you said, but you said one of the things that gets in the way of you taking care of yourself the way you wanted to, and you listed things like exercise and other kinds of things, but what got in the way of that was how you see yourself. And a lot of that was driven by your social world, and how you're perceived, how other people perceive you, how you perceive yourself, how you think other people are perceiving you. Is that kind of what you described there? Sure. So let's pull that into sort of a wider sense of how we relate to ourselves and what we see as, whether what we get preoccupied in that takes us away from being able to take care of ourselves, or when we have a difficult or negative or harsh relationship with ourselves that may get in the way of feeling like we can take care of ourselves. Right? How many people at one point or another have been self-critical in some way? Okay. So we're tough on ourselves, hey? Right? some of us extraordinarily so, but all of us, right, almost every hand went up. All of us are tough on ourselves, right? And so it's, you know, when we're in a process of judging ourselves or criticizing ourselves or being very preoccupied with how other people see us or beating ourselves up, does it really feel like we have sort of the energy, interest, investment in taking care of ourselves? So, you know, as an example, we're going to come back to that one, but as an example, right, it's not just so much as, you know, oh, I don't know what to do to take care of myself, but what are some of the things that get in the way? So my relationship to myself and to my social world may get in the way. Let's come back to that. What else? What else gets in the way? Yeah.
I find that sometimes, as a sufferer of OCD, my drive for intense perfectionism makes me feel like, oh, I can't just start exercising. I need to be the person who immediately can run a marathon, and that actually causes me to give up on a lot of things. If I can't do it perfectly, then I'm not going to do it at all.
Okay, so perfectionism and what we sometimes call all or nothing thinking getting in the way. So whether you suffer directly from OCD or whether you are the caregiver or a family member of somebody who's suffering, we're all susceptible to that notion of all or nothing, right? So either I do this, you know, either I go all out, right? So exercise, right, as an example, right? So either I, you know, you said run a marathon or something, right? So either I exercise for, 3 hours a day, or there's no point, right? Or, you know, if I'm caring for somebody, I have to care for them 24/7, or, you know, or I'm not getting it right. I'm not being a good enough family member, or I'm seeing some nodding heads. Okay, so our relationship to ourselves, some of the thinking patterns that we get in terms of sort of, I have to go all the way, or nothing, again, whether as caregiver or as person with OCD. Anything else that gets in the way, especially as a caregiver, of taking care of yourself? Yeah. Mm-hmm.
I'm so grateful for the cookies that did. It's not prioritizing
Yeah.
properly, but at the same time, I very much felt that I needed to come here.
Sure. So felt you needed to come here. It was important to you, but you got a lot else on your plate, right? And you know, that little sort of, and then that slightly critical voice in your head said, I'm not prioritizing properly. Well, you got a lot on your plate, and it's hard to prioritize, right? How many people feel like you want to take care of yourself, but it's the last thing on the list, and as long as I get through all the other to-do things, all the other things on this to-do list, you know, then there's time, except that, you know, there's never time at the end of that, right? So, so how do we make space for that? Yeah. What? Maybe one more. Yeah. A sense of disconnection.
So constantly being attracted to distraction, so you don't have to deal with yourself. You
So,
have to sit with your own feelings.
sure. So the level of distress that that any of us can experience can be such that we don't want to sit with it, and so get so caught up in all kinds of distractions that we don't feel like we're taking care of ourselves, right? So not only our relationship to ourselves, but our relationship to our own distress. And are we taking care of ourselves psychologically in that sense, right?
Very easy mind and a cluttered mind.
Sure, yeah, okay. Maybe one more thing that gets in the way of you taking care of yourself? Yeah.
Loving others a lot is, you're more worried about them than yourself.
Right. Loving others a lot, more worried about them than yourself. Right? There's an old adage that, a parent is only as happy as their least happy child, or, and so on and so forth, right? So that sense of, where do we fit in when we, especially as a caregiver, that says, if somebody needs so much care, is there any room for me? right? Or, do I deserve that? Is it a priority? Does prioritizing taking care of myself get in the way of me taking care of somebody else? Can I even think about what my needs are, in the face of everything I have to do for everybody else in my life? Yeah. Okay, so this is not just, that we need some kind of list of, let's eat right and exercise and get plenty of rest and that kind of stuff, right? There are all kinds of things that get in the way of us doing what we need to do, right? And let's talk through a little bit more of some of those in the time that we have. But the most important thing from my 15 minutes that you're going to leave from is genuinely is not what I'm saying, but what you're identifying for yourself in terms of what are the things that are getting in the way of me taking care of myself, right? And my invitation when you leave tonight and when you're kicking around tomorrow and the next day and whatever, is to actually, in a curious and friendly way, check in on some of those assumptions or some of those rules or some of those things, right? So like that last point, right? That assumption, that rule that I have to take care of everybody before myself, right? Or that everybody else's needs are more important or whatever it is. Just wonder about our relationship with that rule and what its impact is on us, right? And sometimes we do a workaround. How many people have taken an airplane in the last while? In the last year? How many people have been on an airplane? Cool. Okay. Where you got? Everyone tell me where you've been. No, sorry. Right, but that sense of, so we've got this little workaround that lets people that are too concerned about other people still take care of themselves, which is you got to put on your own oxygen mask before you help somebody else, right? That's what they tell you at the beginning. And that can be helpful, but it's also, I call it a workaround because, it's still kind of saying that other person, sure, I mean, when we love somebody, we think of them as, maybe more important than ourselves. And I'm not going to tell you where to put that piece, but that's actually the all or nothing creeping in that, to love somebody means I can't love myself. To take care of somebody else means I can't take care of myself unless I'm taking care of myself in order to take care of somebody else better. Right? You may want to ask yourself, separate from all the other people in your life that you're doing all these things for, do I deserve also to be cared for in some way, right? And that's a complicated question that I imagine many of us have struggled with over time. But getting at that sense of what is getting in the way for me, whether it's that kind of piece. So my relationship to myself, my relationship to other people, right? My physical well-being, my psychological well-being, and checking in with ourselves around these barriers. So it may be something about my relationship with myself. It may be something about my relationship with somebody else. It may be something about how I prioritize. I may think that taking care of myself is really important in the big picture, but it never seems to find its way into the day because everything in the day feels like it's more important. Or it may feel sort of too big to put something in to my day that takes care of myself. Or it may be a logistics issue. The person that I am taking care of as a caregiver may have such high needs, and I may have no other support in order to do that. It may literally just be a logistics kind of thing, right? Some of you may have had to do all kinds of things to be here tonight in terms of the logistics of making sure that somebody else is being cared for. So again, in each one of these pieces, though, there's an assumption that we may want to reflect on, right? So do I have to exercise 3 hours a day for it to count as exercise, right? Or can I walk around the block? Or if I can't walk around the block, can I walk down the hall and see what happens, right? If I'm taking care of myself, am I actually betraying this person that I care about? Right? The emotions that I feel that I want to get away from, whether they're about stuff that's going on in my life or the complexity of my relationship with this person, in my life, right? If you're caring for somebody who's suffering, you may have a lot of sympathy, empathy, vicarious distress, whatever you want to call it, but you may also experience guilt or anger or frustration or all kinds of things that you may feel you're not allowed to feel, right? And that makes it very uncomfortable to sit with it. Right? So, what's our sort of willingness to acknowledge our own distress that may get in the way of us taking care of ourselves? Right, so we got a couple of minutes. I want to highlight a couple of things. So one is the concept of compassion. Compassion. Self-compassion, compassion for others. What does that actually mean in 60 seconds or less? In 30 seconds or less. What does that mean? So compassion for yourself, compassion for somebody else, doesn't mean letting yourself off the hook or holding yourself not to a high enough standard or the same for somebody else. Compassion means, let's break it down into a few things. One is acknowledging the suffering that's here. Not in order to get rid of it, but you may be suffering, or somebody you love may be suffering. Right? Acknowledging that this is suffering, and it's difficult. Right? We gave you a lot of tips today about how to not accommodate and what you can do and how CBT works and that kind of stuff. But this is hard, right? And being able to get it right all the time is also hard. Right? So acknowledging that there is suffering here, not to chase it away necessarily, but because it's here. Another part to compassion is what we call the human lens. Understanding, not through a lens of perfectionism, as you said, easier said than done, but through a human lens. We don't make mistakes because we're broken somehow. We make mistakes because we're human beings. And when we err in some way, it's an expression of our humanity. So can we see ourselves and our loved ones as human beings doing the best we can, both whether we're caregiver or whether we've got an illness like OCD or anxiety or something like that. And then the third piece to compassion, again, whether compassion to yourself, compassion to others, is a sense of kindness amidst whatever is going on. Can I treat myself kindly, and can I treat the people around me with some sense of kindness amidst whatever's going on, right? And that's a practice. That's something that that we get swept up in all kinds of things that get in the way of that. But offering compassion to ourselves, offering compassion to others amidst the difficulties. Marilyn told us this is a journey for many people in all kinds of ways, right? So this is not an overnight solution in any kind of way. So can we give compassion along that process to ourselves and to others? So in 30 more seconds I'm going to stop, but what I'm going to invite each of you to do on your way out tonight, in conversation with someone else or just with yourself, tomorrow when you wake up, is to give a little bit of reflection to whatever popped into your mind as the barrier right now for you taking a little bit better care of yourself. Not doing something massive or whatever, but tomorrow taking slightly more care of yourself than you did today. What is getting in the way of that? Does that have to get in the way? Can you test something out in your life that makes a tiny little bit step in the direction of taking care of yourself a little bit better tomorrow than you did today? And I'll leave that to you. Thank you.
Thank you so much, Stephen. And I'd now like to invite all our speakers to come up, and we are going to have some time now for some questions. And I want to thank you in advance for all the wonderful questions that I have been given, and there is quite a variety here, so we will do our best to get through as many as we can. And if there are still some others, feel free to put your hands up, and we will do our best to get to them as well. Okay, so we have everybody up here? Great. let me start with maybe a couple of quick answers. So there was one question concerning what the Thompson Center is doing in terms of whether there's any treatment here for mild to moderate OCD. And the answer is absolutely. Our focus right now is on trying to offer treatment to the most severe specifically because they have nowhere to go in the country. Actually, ours is the only treatment program currently running in Canada that specifically offers very intensive treatment for people who may warrant it with very severe OCD. But having said that, in our local community, we're available to anyone with OCD for referral. Beyond our local community, if the OCD is a bit more significant, disabling, meaning they've failed a few treatments, the information's on our website, and we do our best. And the other kind of help that we can also give is we have something we call an MD to MD consult service. So any doctor who wants help with somebody or wants advice about how to best help a patient with OCD can also contact us, and we will set up a phone call, typically within a few weeks, a month at most, to give some advice that way over the phone. The other question that came up a number of different ways was around opportunities for getting help for children. And I just want to say to those in the audience with that is probably one of the worst situations, in that there is a real lack of mental health treatment availability easily, I would say, across our country generally. But when it comes to youth, it's particularly acute. So one nice thing to keep in mind is there is something now called the Family Navigation Project or Family Navigation Program. It's run out of Sunnybrook, headed by Dr. Anthony Levitt, and has been in operation for, I believe, about 4 years now. And they will help family members or an individual aged 13 to 26, anywhere in Ontario, help connect with local services. It's totally free, and they will stay involved until you are connected. So that's called the Family Navigation Project, and we can make sure that that goes up in the slide deck from tonight. Again, if anybody writes that down, you just have to Google that, and their website comes right up as well. So that's some. Yeah, we will put it up on the website. We will put it up in the slide deck from tonight, or you can perhaps speak to one of us, but I'm sure their phone number is available if you call directory assistance as well. They certainly do have phone access because people typically end up in phone calls with them. So there is that. We also do have a wonderful youth psychiatry program at Sunnybrook. We're one of a number of sites across the city, and certainly for general services, any youth psychiatry program should be able to provide some services for families dealing with OCD. Our next question was an interesting one that can be particularly challenging, which is how can you try to help somebody with OCD who is reluctant to come forward for help, who may be secretive about it, suffering in silence, staying quite isolated. And so I'm going to leave that open. I don't know who on our panel would like to take that one.
Sure, I can. So yeah, I think we hear that. Oh, sorry. We hear that a lot from family members or friends of individuals with OCD, and it is tricky. I mean, I would encourage you, as the friend or family member, to learn as much about the person's OCD, and then maybe trying to even see if they'd be willing to hear about what you've been learning, maybe share some resources if they're reluctant to start. I think also trying to get to figuring out what's making it difficult to sort of talk about, or what are they worried about. So trying to get to some of the emotion that might making them feel reluctant to get help, or their readiness to get help. Maybe it's because they're not sure what help will look like, and so they might want some more information about that. So I think trying to really get a good understanding from that person about what's getting in the way, and maybe that can be the dialogue to start with.
Yeah, I think that's great. I think what I would just add to that is you don't need to get too far ahead of things. So right, so what's the next step? So you don't need to get too far down the road of treatment or something like that. Is this person willing to have a conversation with somebody that's not committing to anything or anything like that, right? So just kind of thinking in terms of the next step.
Okay. Another question that came up in a couple of different forms was around OCD and whether it is necessarily something that evolves over time to become severe, whether it is always going to be chronic, and whether it can change forms over time. So I wonder, I don't know, Steve, do you want to start with it? And then maybe we turn over to Ketrina and
Sure.
Sandra.
So, look, I mean, I was supposed to say the short answer and then give a really long answer. But OCD comes in different shapes and sizes for people, and it can be what we call sort of waxing and waning. So the symptoms flare up and then they go down and they can come back. And so, you know, we have to be realistic that there is some kind of chronicity. This can be a chronic illness for many people, but it can also go through long periods, if not, indefinitely, where people are doing a lot better. And so I think it's important to be hopeful and access treatment when we can, because people can do remarkably better. But it's also reasonable to not have to not expect that this is easy for somebody to overcome or easy to treat right away or any faster than it's going to be.
Yeah, and I was just going to say, too, that I think it can change over time in terms of the types of OCD that can occur. And I guess the good news is that if someone is receiving treatment and their type of OCD changes, so maybe they're doing well for a period of time, but then maybe they have a new type of OCD, a lot of the treatment strategies, the CBT and the exposure and response prevention are the same for regardless of what the type of OCD is. So they don't have to go back to the beginning. They might just have to figure out how can I apply those same things that the person's learned to whatever type of OCD might be presenting if it is changing over time.
Thank you. And I also just want to point out, in the same way that it can change over time, it's certainly most common, in fact, for people to have multiple symptom types of OCD at the same time. So that, in fact, is not unusual. It's not marking their illness as more severe. It's actually the way the illness often presents. We just tend to often focus on one type of symptom at a time for simplicity's sake, as a way of teaching about it. We had a few questions come up for Mary Lynn. Wondering if Mary Lynn would feel comfortable commenting on whether she sought or obtained any kind of medical treatment in general, and did you manage to get back to work, or can you, and also whether you feel that your experiences have in some way helped you in terms of moving towards what you want to do in life?
I did receive CBT therapy at CAMH. It was a 12-week group program that I attended. And then I also did a mindfulness research study here at Sunnybrook called the Muse. And I found both to be very, very helpful. And I was able to, in addition to what I had done through my own education, it just further taught me some more tools to be able to manage my OCD. Mindfulness for me has been huge and continues to be. And then, no, I'm still on leave from work right now. It's, I think, going through this experience for me and kind of it all coming to a head and then going straight into kind of survival mode as it felt. Things have changed for me. My outlook has changed. Where I want to put my time and energy has changed. So I'm still employed, but trying to figure out where my next move will be.
Thank you, Mary Lynn.
Peggy?
Yeah, please.
Yeah, I'm just going to piggyback on what Mary Lynn said there in terms of So mindfulness is increasingly being available in all kinds of places, including here at Sunnybrook. And we're actually quite hopeful both. So we've had a few studies here at Sunnybrook that have suggested that mindfulness will be helpful in OCD. But it's also helpful in the last topic that we just talked about, which is taking care of ourselves as caregivers. And so, in that spirit of looking for help when it makes sense, mindfulness, as a caregiver, you can, even if you don't have, say, anxiety as a disorder or depression as a disorder or what have you, you may find a program like mindfulness to be helpful in terms of managing your own well-being. And again, it's available here, but available at many hospitals and programs around the community.
I just wanted to add one more thing for those in the audience or for family members that experience more so the obsessions and mental compulsions. Acceptance commitment therapy is also something that has helped me. I haven't gone through an actual therapy session, but it's something I hope to do in the future. And I believe, I don't know if you all offer it here, but I know that you guys are very much trained up on acceptance commitment therapy as well. So it's another area I think to pursue along the way in looking at different therapy options.
Yeah, I just want to point out again that usually as physicians or as professionals in mental health, we start with where the evidence is and then we move on to other things. So the best evidence we have currently is for cognitive behavioral therapy and medication, but increasingly we recognize the limitations of those treatment, and we're finding huge value in adding in other elements like mindfulness and acceptance and commitment therapy. But I wanted to say that just by way of kind of saying that's not usually where somebody should be starting, because you want to start with things that pack the biggest punch if they can help you first, before you then move on to that. As a caregiver looking for help, I think they can offer tremendous value as well. One question that came up from a number of different people in a number of different formats was around what the OCD-related disorders are, what is the relationship between them, and so I thought I'd just briefly speak to that. So certainly OCD is part of a spectrum of conditions. We now call them, in fact, the OCD and related disorders, and those include problems such as hoarding disorder, in which people have difficulty with discarding things and end up accumulating more stuff than they can accommodate or manage. There are also problems like compulsive hair pulling, otherwise known as trichotillomania or hair pulling disorder, which has been around for a while, but I think is now more readily recognized by mental health professionals. And skin picking disorder or excoriation disorder, which is a sister condition in which people have problems with excessive picking at the skin to the point that they really can damage themselves, which previously actually didn't have its own kind of line, if you will, about being a diagnosis, and something called body dysmorphic disorder. So certainly these are all things related to OCD. We do have a little bit more information up on all these things on our website or at the International OCD Foundation website, and those links were in tonight's talk and are up on our website as well for those who would like to know more. I think this is a really interesting question, which maybe I'll throw towards Ketrina and Sandra, which was, when a family member is going through an anxiety attack, what are some of the most helpful things you can say to them to kind of help manage their fears in the moment?
I guess I think one thing that might be helpful is to really normalize their feelings. That what they're feeling in the moment, probably it's normal, and validate those feelings. And maybe after talk to them, what are some of the things that they might find helpful in that moment that you can address with them the next time that they might feel anxious or stressed out or panicking.
Yeah, and I think sometimes, again, maybe it depends if the person is willing to sort of talk about it with you, but even helping them to start to describe where the anxiety is showing up in their body can be helpful and can sort of help to actually get some space from the intensity of it. So what are they noticing is, in terms of their heart might be racing faster or knots in their stomach. So sort of helping them to describe the anxiety. And I think, as Ketrina's saying, if maybe some things have worked in the past, like maybe as distraction tool or doing some grounding together, then it might be useful to remind them of that, because in the moment when that anxiety's taken over, they might forget, or they just might be so focused on the emotion that it's hard to recall what's going to be helpful in the moment. So maybe there's a pre-agreement of what can you do or say when that anxiety is showing up.
I think that point about grounding is a really interesting one. I'm not sure how many people here are familiar with what we mean by grounding, but really grounding, there's a variety of techniques out there as a way of helping the individual focus on where they actually are rather than what the worry is telling them about, because our worries are typically about things far removed from where we are in the actual moment. And so grounding is helping the person come back to realizing, right now I'm here, I'm in this space, I'm with whoever I'm with. So we may ask them things like, for example, focusing on their senses. What do they smell? What do they feel? What's the temperature like? If there are objects nearby, can they describe or focus on an object? For example, my water bottle. What does it feel like? What's the sensation? Is it smooth or rough? Can I describe it? And these can sometimes sound very trivial or odd to people, but these are just ways of getting an individual to focus on what's actually in reality, in the here and now, and helping them, as Sandra and Ketrina both kind of mentioned, get some space from the panic and the anxiety. And I think it also never hurts to start off by asking, how can I help you best right now? Because they may have a very good idea of what kind of help they want. And sometimes it's best to just ask. So those are a few really great suggestions. Thank you. Another question was around whether medication is a necessary part of treatment. Wonder if I could turn this one to you, Steve.
Sure. So when we're talking about OCD in particular, so ideally, as Peggy was saying, I mean, if we want to follow the best evidence, ideally we would like to get everybody into a cognitive behavior therapy training, cognitive behavior therapy for OCD specifically, and for many people that may be enough. For other people, medication will need to be part of that treatment, either in order to make the psychotherapy more effective, or in times when they can't access or participate effectively in a psychotherapy. So it's not necessary to be on medication for all people. It may play an important part in recovery for many others.
Great. And maybe one more question, which is, are there any suggestions around how you can deal with the issue of accommodation if the family member isn't kind of willing to engage, isn't really wanting to work with you collaboratively? Any suggestions for family members in that kind of situation?
Sure. Yeah, I think that's a common one, and that can be a struggle. And I guess depending on what the type of accommodation is that's occurring, it might be trying to figure out what can you as a family member start to pull back on. So even if the person doesn't quite feel ready, so maybe it's if, for example, if it's for a contamination OCD, and the person is wanting the family member to, I don't know, wash all the groceries before bringing them in. So maybe starting to reduce that, even if the person's not quite ready for that, but starting to do that themselves as a family member, and just sort of still, reminding them that it's difficult, and we know that it's OCD that's asking for that, but even just reminding them that if I keep doing this OCD request, it's just going to keep the OCD cycle going. So even though they're not ready, that you might be able to sort of pull back on a few things that you've been accommodating, to trying to have a dialogue about it.
And I want to just say there have been a lot of excellent questions tonight. I wish we could address all of them. I think a number of them are going into a lot more detail around specific types of medication treatment and causes of OCD, and I really think it's a little beyond what we can get into tonight, but they are excellent questions. There are older public forums that we have run in the past where we've talked more about causes of OCD, and those links should still be up on the website. I can also take a look into that in the next week or two and make sure, if we can, that we put one of those back up if it's been taken down. And again, there is lots of good information on our website, so I want to apologize in advance. It's not that they're not great questions, it's that unfortunately we've had a great and very full evening, and I think they go a little beyond where we can go. So at this point, I think we're going to close. I want to thank you all for...
You said you get the website on.
Sorry?
Where's the website?
The website is at Thompson Center. Sorry, sunnybrook.ca/Thompson Center. One word. And I can try and put that back up in a moment, perhaps on the screen. And we also have resource information on the way out. Thank you, Shelley, for reminding us. And Shelley has that information out on the desk in front. So I want to thank all the wonderful staff and volunteers who've stayed tonight to help make the night wonderful. I want to thank all of our speakers. I want to remind people, please, to fill out evaluations if you can, because we really do welcome that feedback, and we use it to inform how we do these evenings to make them better. Also a reminder that we do have free parking passes, and you can ask any of the volunteers for those before you leave. And for information on upcoming lectures, please feel free to visit the Sunnybrook website, because aside from us, there are all kinds of wonderful speaker series talks going on at least monthly here, and that's at www.sunnybrook.ca. Thanks so much for joining us, and I hope you all have a good night.